Okay, thanks,
Hello,
Laura.
lady.
Hello.
Hello.
Hello, it's great to
Let's
see you.
let's pretend we haven't just been talking for 15 minutes.
Which we have.
Hello.
Okay, we're just going to kick straight off with this
Yeah,
because we're on a record. So that's great. Are you good to go, Laura?
I am good to go. We've got
Excellent.
loads to get through today.
Fantastic. Okay. Okay. So, hello and a very warm welcome to this discussion. My name is Joanna Taylor and I am Laura's business coach. I've been working with healthcare brands like NOI Group, Le Pub Scientifique, Pelvic Pain Matters for more than 20 years, helping them to build their businesses and communicate what they do to their desired audiences. So, I am absolutely delighted to be joined this morning or this afternoon by my very good friend and respected pain educator, Laura Rathbone. Good afternoon.
Good afternoon.
So, Laura is a pain specialist, clinician, and mentor to healthcare professionals worldwide. She brings a unique perspective, combining cutting edge science with compassionate, inclusive practice. Laura, could you just tell us a little bit about what you're doing currently?
Well, I am what's called a pain consultant physiotherapist in the Netherlands, which is not a very typical position. So I'm very excited to be working embedded with the pain team here in Amsterdam at the OLVG. I work also as a pain specialized physiotherapist, psychologically informed by acceptance and commitment therapy. And in addition to this, I'm an educator, and I have also been collaborating this year with NOI, working and also I work with Christine Petridis, and we are the co-founders of Pain Geeks, which is an international reading group for clinicians and therapists and researchers and people just interested and wanting to develop their knowledge of pain and sort of sharpen their academic and critical reading skills. So that's what I do. I guess relevant to this though, I've been training people in acceptance and commitment therapy for around, must be 9 years now.
Mm.
Yeah, because I started just before I left London. So that was just before Edith was born. So yeah,
Oh,
nine
thank
years
you.
now.
I know.
Yeah.
Amazing, isn't it, where the time
It,
goes? Unbelievable.
it does fly. It does fly by.
Um, so let's get into the content because we always run out of time. So today's session is designed as an introduction to ACT. If
Mhm.
you've done an ACT course with Laura before, then this will help to refresh and reinforce what you've already learned. But if not, and you want to know more about it, then we'll be introducing you to Laura's upcoming course, which starts in February 2026, and we'll give you details about that at the end. So
Mm.
hang around if you want to learn more about that. We're going to be talking for about 20 minutes. So let's kick off with the first question. Are you ready? Okay, so the title of today's session is intentionally provocative.
We would never do
Does
that.
ACT treat
Oh, oh no.
biggest lie in pain management, the belief that you must eliminate pain before you can live your life. So, Laura, if a patient asks, will ACT get rid of my pain? What is your 30-second answer?
So first of all, rarely does a patient ask me that. The people who ask me that the most are clinicians. So does
Mm,
ACT help people? Like, is ACT going to reduce people's pain, right? So especially non-psychologically trained clinicians at this. I think that the short answer is, well, it might do, but that's not the point. And I think that's sort
mm,
of the hard bit for us to get our head around. And this is why ACT is considered a process-based or a third wave approach to cognitive and behavioral strategies, because it is a cognitive and behavioral therapy. It's just not cognitive behavioral therapy, CBT. Yeah. So it's
mm,
the idea behind acceptance and commitment therapy is sort of acknowledging and I guess accepting as a healthcare profession, as a species maybe, that there are just some things that we can't solve, right? And one of the things that we because it's not, we can't cure with medical interventions because they're just part of being human. So pain is not necessarily, is not the pathology, right? It's not the disease itself. It's a symptom, it's a feeling, it's a way of experiencing your body. Um, and so when we're integrating an ACT approach, we're sort of accepting that as a species, maybe for the first time in a long time, that pain is part of being human, um, and that it's absolutely possible to still live a full and rich life alongside pain. So we're not necessarily trying to directly target the pain in and of itself because pain is normal. It's just that it's showing up in an abnormal
Yeah,
way for that person. So what we're actually trying to do is move the marker on more whole person approaches. So thinking about how this person is expressing their identity in the world, how they're engaging with values based sort of activities? Are they able to show up for their family? Are they able to, hold a sort of a meaningful place in the world? Um, and so
yeah,
it's really moving away from that mindset of trying to, I suppose, fix pain and working towards trying to support the person more. So it's a shift in approach.
sure.
Yeah. So,
So tr
yeah.
traditional approaches focus on pain reduction. ACT focuses on something completely, entirely different. Is that right?
Yeah. So in acceptance and commitment therapy, we talk a lot about the struggle, right? So we're mostly focusing on this sort of this just I mean, in some ways, I think ACT is such a humanist approach, right? Because it's just saying like being alive is really difficult. Being alive in the world is really difficult, and you're constantly being faced with struggles or choices where to put your energy, and that's because we're biological, right? We're not machines. This is something that we is really important because we often use machinery metaphor within healthcare, right? But we're not machines, we're biological, which means we only have a finite amount of energy that we can use in our waking day, right?
Mm,
So we have this like as very complex biological conscious systems, we have really hard choices to make. Where do we put our attention? Where do we put our energy? How do we use our time? And acceptance and commitment therapy is really honing in on like on that process, on that moment, and saying, well, if we are always making choices that are outside of our values, that mean we never get time and space or energy to express ourselves in the world, we're going to start to feel really distressed, and we're going to start to feel
mm,
like we're really in this sort of conflict in our identity. So rather than trying to sort of uh, rather than struggling with sort of like it's basically a way of saying how about we try to make choices that are focused on what's important to you rather than getting rid of stuff that you don't want, especially if that stuff is something
sure.
that we can't get rid of, right? So we often use the metaphor of like a Chinese finger trap. So if you've got your fingers inside a Chinese finger trap and you pull, it just gets tighter and tighter and tighter, right?
Right.
And the idea is that when you're in the trap, the logical thing is to pull away, is to try and pull your fingers out. Almost
Mm,
like the opposite would be, but actually to loosen the trap, you have to push your fingers together.
yeah.
So you have to go into the struggle. You have to almost drop the struggle. You have to stop trying to pull away, stop trying to solve it, and just allow it to be there. And then there are other options. And so it's about trying to drop one struggle so that we can effectively struggle in other areas because it's
Yeah.
just you know and when we're doing that we're constantly using like what's important to you as a human being, which
That's
I think is
fascinating. I remember when I did the course with you, you talked about this, and that is just such a great visual representation of that,
yeah.
not pulling against it, but actually leaning into it. Amazing. It's
We
really clear.
Yeah, I mean, we call this experiential avoidance, right? Because you don't want the thing, you pull away from it, right?
Yeah.
Um, but the more you pull away, the more you get intertwined with it. And that's just something, I mean, and we've got sort of like theoretical models for that as well. When we think about attention and saliency, like pain is a highly attention grabbing experience, or
Mm,
maybe it requires a lot of attention in order to be an experience. These are up for discussion, but like whatever is happening, the more we attend to it, the more enmeshed with it we become. So what if we started attending elsewhere? What would happen to that? If,
mm,
and that's really helpful. Like the last few decades work coming through that's recognizing pain as a perception over a sensation has
mm,
really shifted like our sort of like our approaches in pain care from trying
mm,
to fix the thing, which is paying attention to it, to acknowledging that the thing is there, that this experience is there that we don't like and we don't want. But if we put our attention in other places, not distraction as in the sense of avoiding, but distraction in the sense of still being able to attend to other things whilst this thing is happening.
yeah.
Yeah.
So
What difference would that make?
the word acceptance can often make people nervous because it can sound like giving up. How do you distinguish acceptance from defeat? And what does it free you up to do?
Yeah, I think this is one of the it's a hard session to have with patients and
Mm,
clinicians. I think sometimes with clinicians it's really challenging because we are kind of afraid of what this might mean to our patients because we're
mm,
afraid of them giving up, right? We want like there I have never met a therapist that is like, I want my patients to give up. We want to keep nurturing hope. We want them to have we want people to have a full life. Like we're in this job to help other people
mm,
thrive. That's what the role is. So we are so afraid of them losing hope because we know how important that is. But at the same
mm,
time, we do have to have this conversation. So acceptance does come with sometimes with this baggage. The best way that I think we can deal with that is just by talking about it, and like trying to, and I said this a few times, like we have to calibrate around words. Words don't always mean the same things to me as they mean to you. Like I'm from Lancashire, so obviously we use words properly. You're from Yorkshire, so obviously, you've no idea. Like, that's very much an English joke.
That's a very, if you're English, you'll understand that.
No, but like we have different words for the same
Mm,
thing, and we have
yeah.
the same words that mean different things. And acceptance in my linguistic sort of architecture in the background might have lots of like inspirational overtones to it because acceptance is something I'm training. I use the word acceptance all the time, like all of this stuff. But to my patient, they might have been told by lots of clinicians and people around them, you've just got to accept it.
Mm,
Now that's a very different feeling around that word. So if I'm using acceptance all the time, I'm going to keep triggering those
yeah.
past experiences. So then we have to figure out, well, maybe acceptance isn't the right word. So let's calibrate on the meaning, the feeling of the word that I'm trying to capture, right? And the feeling and the meaning of the word that I'm trying to capture is this sense of willingness. It's this sense of moving forward. Um, I'm not sure whether you were with me all the way through then. I think
I
my
just lost you
yeah.
after you said, I'm not sure if acceptance is the right word. I knew you were coming back, so I just waited.
Yeah, so I don't know if everybody else on the recording will see that or not, but
They will
I,
see the pause. So you just need
yeah,
to repeat that last bit of what you said.
yeah. Oh, okay. So what I was talking about is that acceptance might not be the right word for us to use between us. We might have to
Yeah.
choose a different word.
Yeah.
Or it might be that we can update the meaning of acceptance to a shared meaning, and that might take a
Mm,
session or two, maybe even longer, right? But
mm,
it's important to do that work with someone and to sort of name the elephant in the room.
yeah.
And I tend to connect to the feeling of the word rather than the meaning of the word. So
100%.
what I want us to share on, and I want us to meet the place that the meaning I want us to meet each other in is this
Mm,
sense of willingness. It's this sense of movement, and willingness is often a sort of an ex it's acceptance is often used with a termed willingness in acceptance and commitment therapy as well. So I want people to get this sense of it's not that I'm giving into this thing, it's that I'm allowing this thing to be present.
Yeah.
Because really there's no other choice. It is present, right? That's the hard bit, is
Yeah.
it is present. And it isn't something that you can just get rid of because you would have done that already.
Mm,
So really what we're doing is just taking a very pragmatic, and that's
mm,
important because ACT is sort of predicated upon it's founded in pragmatism, this very pragmatic sort of, well, a spade's kind of a spade. So like let's call it that, let's
yeah.
acknowledge it, let's observe it, see it for what it is, and then figure out how we move forwards with it.
This is one of the things that I loved about doing the ACT course with you, was that it was about the clinicians understanding this experience for themselves,
Yeah.
so that then you become much more able to understand what your patient is going through. And it just puts you in a different space of what sort of confidence, in one way, that you have to confidently be asking the person to accept what's going on for them.
Right, but if you, and I know we've talked about this in probably every session, but if you as a clinician, if you are noticing, and you might not, you might have to spend some time figuring out how to notice, but if you are afraid of pain,
Yes.
then then that's not going to be an easy therapeutic space for the
No.
person to accept pain, right? So if we are afraid of, if we're like, we can't, if we can't have pain in the room,
Mm,
then that person is going to find it really difficult to also to then lead the way, because they're going to have to guide you and
mm,
teach you how to have their pain.
yeah.
um, and I've said this a few times, like, can you imagine that in any other healthcare specialism? So could you imagine a cancer specialist being afraid of cancer,
Yeah.
being so afraid to say, yes, you've got cancer, like to not be able to say, this is a very difficult diagnosis. Like that just makes no sense in any other healthcare situation. So
Mm,
if we are working with pain, as most physiotherapists, I'm physio by background, are, we are going to have to really get comfortable with it very quickly. And the reality of pain is that sometimes it goes away and sometimes it doesn't. And
yeah.
that's hard. Sometimes it makes sense and sometimes it doesn't. So we have
Mm,
to have frameworks that catch us to be able to navigate that as well.
yeah. Thank you, Laura. That's amazing. Um, so we're just going to move now into sort of the next section of this, which is let's looking at confusion. Large systematic reviews show ACT is highly effective for chronic pain, yet simultaneously reports small or effects. Sorry, contradicting effect sizes on pain intensity. So, what does this research paradox fundamentally reveal about the goal of ACT? Why is the
Yeah.
pain score often a distraction?
I love ACT research because, like, on the one hand it is it's so difficult to, because we're evidence-based clinicians, right? So we're always trying to find the bit in the evidence that says, do this. This is the right thing to do, right? And that's just not how evidence-based practice really works. Um, but if we think about if we think about ACT as a standalone psychotherapy, like without thinking about any other psychotherapies, ACT can be very effective in supporting people to manage their pain for different reasons. We see some shifting in pain intensities. It's rarely held at long-term follow-up, and it's contradicting. So some papers might show a good effect size, some papers won't, depending
Mm,
upon the methodology, and it's really that it's not a very reliable metric. What tends to be more reliable is things like pain-related function, so being able to function despite pain, Um, and pain catastrophization seems to be quite a
Yeah.
reliable metric, and like depression and anxiety associated with living a life with chronic pain seems to be quite a reliable metric. We do
Mm.
seem to see those changes. Um, so what that's telling us is that it is entirely possible for people to live richer, more contented, more satiated, more values-informed
Mm.
lives with pain, right? Because we see these metrics move, but we don't necessarily see pain move, right? So people are having better lives in the presence of their pain. Um, when we put that all together with other psychotherapies, it doesn't really seem like ACT is better but then one or the other. It's just
Right.
another option that supports us in supporting patients, right? So CBT seems to be doing is also quite good. Like we see sort of like also overall these kind of function metrics shift. Um, and other sort of dialectical approaches to therapy,
Mm.
mindfulness based approaches, also quite helpful. So it's not like ACT is significantly better. ACT is very accessible though, which is one of the key reasons why I use a lot of acceptance and commitment therapy because I'm not a psychologist. So it's very accessible for non-psychology trained clinicians. It's something that we can use, we can gain access into, and it's focusing on not changing the pain, which
Yeah.
in a chronic pain situation feels more pragmatic to me and
Mm.
more usable. So the complicated thing is if you're a non-psychology therapist, you're probably looking for research that shows you how to reduce pain,
Yeah.
which might mean that you find it very hard to get into the ACT world. But if you then integrate ACT into your practice and you start looking at what does shift, actually you might understand your professional approach a bit more, which is about helping people live their lives in the world.
Yeah. It always seems to me that it's like it's part of a set of skills, but such an important part for the clinician.
Yeah, maybe.
It
Yeah.
to have this as part, I hate the word toolkit, but you know what I mean, to just have this level of understanding as one facet of helping the person in front of them, but as much for helping the clinician to be in that
Yeah.
space with the person in front of them.
Yeah, I think so. And I think that's really important as well because pain is very distressing, not only to have, but to bear witness to, right?
Mm.
It is distressing to see somebody in pain
Mm.
and to feel powerless, to feel on something that is beautiful about human beings,
Mm.
that we don't see across the sort of the animal kingdom. And I'm not an expert, so please correct me, but human beings do help each other, right? We are very concerned with making sure that the other of us survives. And
Yeah.
like you only have to go back in anthropological studies, but like they say, like the moment that humans became kind of humans and collaborative is, when they started seeing healed fractures in skeletons because in order to survive a fracture you need to be cared for, especially something like a femur. So
Mm.
something about human beings means we do want to help the other person, and so that part of our, I don't know, way of collaborating is sometimes triggered when we're in healthcare, right? And so we have to sort of support the clinician to be able to bear witness to the pain and still be able to sort of make decisions and see the
Yeah.
pathway and to work them through the whole process. And I think ACT is a way of us doing that. And I know you said like I don't really like the idea of a toolbox, and I can totally get it. Um, but ACT isn't a tool within the box. ACT is the box.
Yeah, that's what I was trying to articulate. It
Yeah.
is the sort of it's the thing that it's the container, isn't it? It's the thing
Yeah.
that wraps around every other thing that the clinic
Yeah.
that every other skill that the clinician is implementing
Yeah.
wraps around that
Yeah. And
act.
and it's not new for physiotherapists or non-psychology trained clinicians, medics, whatever, to be informed by a psychotherapy. Like the first work on this sort of hybridizing of physiotherapies, as far as I'm aware, was back in the late 90s between Professor Amanda Williams and physiotherapist Vicky Harding. And
Mm,
they're very rarely credited with that because it wasn't a peer-reviewed journal. It was topical issues in pain papers. Um, but like they were saying then, we are as a profession already informed by
yeah.
psychotherapy, so let's make sure we do it well.
Yes.
Because
100%.
because psychology is much bigger than physiotherapy. I was just talking to Mick Thacker the other day, and he was saying the same thing. And I think this is where I've got it from over the years because it sounds like it sounds clever, so it must be Mick. Right.
Stop.
Physio is a baby profession. We're only 150 years old, maybe not even that, 100 years old. Like we're a baby profession, but psychology is like thousands of years old. So
Mm,
like we are a baby, and psychology in its current form is hundreds of years old. So we are a baby compared to that. So we stand to gain a lot from
yeah.
understanding our psychology colleagues and the theories and the frameworks and the experiences and the observations, because of course psychology is not created, it's observed in others. So it's
Mm,
and then written down. So like we stand to benefit from all of that. So when we're informing our practice with acceptance and commitment therapy, we are moving towards a sort of an approach to supporting people that focuses on function, disability, and improving that person's
yeah.
emotional coping and well-being in the world. And if you can't move your body, if you can't use your body to interact with your world, you're going to really struggle to be satisfied in those domains.
Yeah. Amazing. I was going to ask you to wrap up, but I think you've just done it. I
I
think
hope so.
that's a great place to finish there. Thank you, Laura. Thank you so much. So just before we jump off here, for anybody that would be interested in going on this journey with Laura and understanding what she's been talking about today and in the two previous webinars that we've done, then Laura does have an upcoming ACT course.
Mhm.
It's online, so you can join from anywhere in the world. It starts on February the 3rd, 2026. And Laura, just briefly, what could people expect to come away with if they were to join you on that course?
So my hope is that people come away with a couple of things. Firstly, they come away with an idea of how to safeguard their own well-being and how to build their own sustainable practice when
Mm,
working with people with pain that brings up distress in them, right? So that might not be chronic pain, but it might be. So really hoping that it just supports people to manage their own stuff at work. And secondly, that you have a really good understanding of the framework of ACT and an underpinning understanding of the theory of relational frame theory and the sort of philosophical ground that ACT has emerged out from. Yeah,
mm,
because acceptance and commitment is the psychotherapy framework. It's the what we do in the clinic. But underneath that, there is a psychology theory and then there's the philosophy. And if you've got a little bit of insight into all of those things, you're going to be more liberated, more free. Oh, there's Bobby. Um,
yeah.
more able to flexibly respond to what's happening in your clinic. You're going to be able to be more creative. You're going to be able
Mm,
to make rather than becoming more like an ACT therapist, you're going to be able to intertwine this theory with your style, with your practice, with your way of understanding therapy, and using your evidence that you've found to build what is hopefully a very unique and helpful practice for people who are asking for your help.
yeah.
So that's what I
Yeah.
hope people come away with. And we're going to do that over 4 weeks. So
Yeah.
with about 12 hours of direct contact teaching between me and the group as a group. And then there's going to be some additional recorded work. And it is really exciting because I have taken a bit of a break. So it is now updated. I'm
Yeah.
rebuilding this whole course based on all the stuff I've learned over the last couple of years as well, and how that's maybe just matured my perspective a little bit.
Yeah. I would just like to add that I did do the course with Laura a little while ago, and it is like a journey of self-discovery. It's not just a course where you go and learn a load of kind of stuff and you have it fired at you, and then you sort of absorb all this new information. You really go through it in a positive and interesting, it's so interesting way. And the people that you meet on the course, well, we've said this before, Laura, they actually have become friends
Yeah,
because you get to know people. It's just such a, it's like an opportunity to make some new friends
yeah,
and learn something that's like not only
yeah,
going to be useful to you in clinic but in
yeah,
life.
yeah,
It is something that I feel is, it's like about being human, really, and
yeah.
such a sort of journey of discovery for yourself, as well as to improve what you're going to be able to do with your patients. So it's so much more than a lot of the courses you know um, that are available. And
Well,
Laura, of
yeah,
course, is just amazing. I love her,
yeah.
and
Oh,
you just bring it all to life, and you're so passionate and you care so much that
yeah,
it is, and it's just great to spend time with you because you really do know this stuff inside and out, and that gives everybody on the course the confidence to practice and learn what you're teaching because you really do understand it and you understand the people that are learning from you.
well, we're all learning, right? Like I'm still learning. And I mean, there's always areas that I find, oh, haven't explored that enough. I need to just tap down into that a bit more and all
Mm.
of that. Um, but I think I remember when I first started exploring ACT, and I'm a really reflective person, right? So I can still remember going home and being like, "What is this that I'm doing? Like, what on earth is this? Like, how is this going to help?" And also then my own resistance. I remember sometimes, sorry, I know we're running out of time, but I remember the very first mindfulness-based stress reduction program I did. I'll never forget. It was in North London. I had to travel all the way over, which is quite a lot in London if you've lived there. Like, because
Mm.
I was in the southeast, so it's an hour and easily an hour to get there, and then sit in someone's front room for like 3 hours, noticing my own breath and my own thought, and I was like, I don't want to do this. Like, I just want to massage people. That's easier. I think I
Did you
lasted.
think about running away at coffee break?
Oh my God, I actually did, Joe. Like, I think I made it 3 sessions before I was like, this is bullshit. And like, walked off and went straight home and booked myself onto a manual therapy course. I was like,
God,
and this was
my
about, I
God.
think it was about 14 years ago. And I was like, and I'd just come off, I think I'd come off Explain Pain, and I was like, I'm going to be Mac. And I was like, David Butler was so inspiring. And I was like,
Yeah.
this is what I'm going to do. And I was like, I'm not doing that. But then, and then it just sort of. So I just said I won't be coming back, and thank you very much. And it was a wonderful course. And now I can see the value of those teachers, but like I just could not get over my own resistance. And it was such a valuable experience because actually even and this is why I don't mind when people leave in the middle of my stuff, or in the middle of like my therapy process. If we get 3 sessions in and they say I can't do this anymore, yeah, I know. I can relate.
If you're not ready, if you're not
Yeah, yeah, yeah.
meeting, then
But also those 3 sessions that I did manage to sit through, 2.5 really, if I'm being honest. Like they were the beginning. I learned a lot. I learned so much. I learned
amazing.
so much from it that I was completely overwhelmed and had to run away.
Yeah,
The mirror was held up to me in such a strong way that I didn't even have the coping strategies to see what I was feeling. I
amazing.
couldn't even
So
observe
interesting.
it. It was so overwhelming. And I don't want patients to go through that 'cause I don't want people to feel that flooded and that unheld.
Yeah,
Um,
sure.
but it was like 14 years ago, so we were in the beginning of teaching healthcare clinicians, and I think I think it now I've been sort of moving with this way of gently supporting people to acknowledge that they are doing a good job. This is really hard. And yeah,
It is hard.
you've got your own stuff that's getting in the way, right?
Yeah.
And let's try and do all of it at the same time because then we can all come out with a more sustainable way of holding that therapeutic space and being with people. Yeah.
Thank you. Thank
Yes.
you, Laura.
Thank
We could
you.
go on, couldn't we?
I could.
But we're not
Yeah.
going to. We're just going to say we're going to wrap up. We're going to thank everybody for watching,
Thank you.
and we hope this session has been useful. Check out the previous two, and there'll be another one coming up in a couple of weeks, 2 or 3 weeks. So we'll hopefully see you again then. So thanks a
Yes.
lot. Take care,
Bye-bye.
everybody. Enjoy the rest of
Bye.
your day. Bye.